Recording in progress. Yes, we can start that.
Okay, ma'am. Okay. Yeah, Dr. Parvati, you can proceed.
Okay, sir. Good evening, everyone. Good evening, everyone. Today I'm presenting a case of CA breast. It's a 45-year-old lady, homemaker hailing from Maldives, presented with complaints of left breast lump for 6 months duration. Are we hearing twice? Is there an echo?
Yes. There's a bit of echo from your end, I think. It's fine.
Okay, sir. So, she presented with a lump in the left breast of 6 months duration. She was apparently normal 6 months back when she noticed a lump in the left breast, and which was initially the size of a grape and increased in size over the last 2 months to the present size of approximately that of a lemon. So, there was no history of redness, ulceration, bleeding, axillary fullness, opposite breast swelling, upper limb edema. There is no history of bone pain, abdominal distension, cough, shortness of breath, headache, loss of weight, or loss of appetite. There was no history of trauma, pain, or any nipple discharge. She underwent a needle testing from the left breast, and some radiological investigations were done 2 weeks back. Coming to the past history, she had a history of right-sided oophorectomy 17 years back for ovarian cyst, but further details are not available. There is no history of benign breast disease or previous breast cancer. There is no history of radiotherapy to the chest wall or surgery to any breast lump. There is no history of diabetes mellitus, hypertension, or coronary artery disease. There is no history of allergy to any drugs. Coming to the menstrual history, she attained menarche at 14 years of age. She had regular 28 to 30-day menstrual cycles, and she attained menopause at the age of 43 years. She is married and has 3 children. First live birth was at the age of 20 years, and she had lactated for a total duration of 72 months. And there is no history of oral contraceptive pill usage or assisted reproductive methods. Sleep and appetite are normal. Bowel and bladder habits are normal. There is no family history of breast cancer, ovarian cancer, or any other malignancy in the family. So, to summarize from the history, this is a 45-year-old lady, P3L3, postmenopausal, with no comorbidity and history of right-sided oophorectomy 17 years back, and no family history of malignancy, no previous breast biopsy, presented with complaints of having a left-sided breast lump, which was detected 6 months back, increasing in size over the past 2 months. So, going to examination.
So, hello.
Yes, sir.
Yeah.
Yeah.
Parvati, I think before we go into the examination, probably you can have a discussion on your history.
Yes, sir.
Oh, I think there is a lot of echo. So from the history, how do you feel the biology of the tumor is? You said she noticed it 6 months back and it has gradually progressed to the current size, correct?
Yes, sir.
So what does that tell us about the biology of the disease?
It is a good biology disease, slow growing.
Okay, it is a slow growing type of tumor.
Yes, sir.
And did you give any history of any lump in the axilla from
No,
as a
from the
negative
history, she did not have any history. She did not
Okay.
say there was any lump in the axilla.
Okay, so as part of a negative history, do you have to probe?
Oh, like she did not feel any lump like that, I have to say. I've
Yes,
written
the
axillary fullness, sir.
axillary fullness we have written. Okay. Right. So you said there's no history of okay nipple discharge. When do you consider a nipple discharge to be significant?
Uh, when it is unstimulated and associated with a swelling and there is no pain.
Okay,
In a patient who is not lactating,
fine. Okay, spontaneous nipple discharge, which is unilateral. Correct? Is that what you said? Unstimulated. Okay, that is spontaneous nipple discharge. I think
spontaneous nipple discharge, unstimulated, unilateral, which is bloody.
bloody. Okay, okay. Those are the kinds of nipple discharge where you would associate significance. Correct?
Yes, sir.
So by a good biology tumor, what do you mean actually? So what dictates the biology of the breast tumors usually?
Sir, is ERPR expression, then
Okay,
mitotic index, that is Ki67 or MIB, which
okay,
is the proliferative index.
yeah,
Then presence of nodal involvement.
okay. Presence of nodal involvement early in the disease. So that is
Early in
probably
the
indicated. Yeah. So if ERPR are strong positive, that means usually these tumors are kind of
good
less
biology
aggressive.
disease.
Good
Yes.
biology disease, which and they would present with an indolent history like this.
Yes, sir.
So we would expect this lady to be, estrogen receptor positive or something like a luminal breast cancer, correct?
Yes, sir.
Okay. So what are the bad biology tumors for that matter?
Usually they are HER2 positive disease or TNBCs, and they will be having a younger age at onset of disease.
Okay.
And at presentation itself, it will be having extensive nodal involvement or metastatic involvement to different sites.
Okay. So the presentation, the course of illness will be much shorter, and at presentation, they may have a higher stage of disease compared to
Yes, sir.
luminal tumors, correct? So the TNBCs are bad biology, but there are certain good biology TNBCs also. Are you aware of any of them?
No, sir.
The prognosis is better compared to the usual TNBCs. So how is the biology of TNBC? Why is it supposed to be bad? One, you said at presentation they may have extensive metastasis, and the other reason, suppose you have treatment.
TNBCs have almost 20% incidence of BRCA mutations. So when they have BRCA mutated,
Yeah. Does that make it a poorer prognosis?
no, sir. We have adjuvant. We have olaparib and
Okay. Let us not go into all that. So
immunotherapy.
one thing probably that you can notice, you do not lead the examiner into unnecessary questions. See, you're giving me an option to ask questions on olaparib. So let us not go into olaparib from the history
Yes.
itself. That probably we can go at the time of management. Yeah, so TNBCs, they have, how is their recurrence pattern?
Early recurrence, sir.
Early recurrence, yeah. So usually they recur within 2 years, and then the prognosis is usually poor.
Poor.
I was asking good prognostic TNBCs. This is basically from pathology that we had. Yeah, okay.
No idea, sir.
Right. So there are medullary tumors. You heard of medullary tumors, right? Medullary breast cancers, mucinous type of tumors. Yeah.
Favorable histology.
Yeah.
They
So
are
those are
favorable histology.
Behavioral histologies are usually triple negative, and some histologies like adenoid cystic tumors, those are TNBCs which have good biologies. Okay, so what else did you gather from history? So from your history, it's a very early stage tumor, probably not involving the nodes. And the size, yeah, regarding the size, when we were PGs, our examiners were not really fond of using these objects to to describe the size of the tumor, like melon, grape, coconut, and all that. So probably, I do not know how it is now, but many of our examiners felt that there are melons of different sizes, oranges of different sizes. So probably you need not use these objects to describe the size. You can probably say small, and it has gradually progressed to the current size. That should be enough, is what I think. Manu, what is your thought on that?
Yeah. Some people will not appreciate mentioning the size because it is okay. I think we can mention just a small as a gradually progressive or rapidly progressive swelling. Mentioning based on the objects may not seem very nice.
Correct. I also agree.
And another thing, Parvati, you have mentioned about a lot of negative history. Could you identify any risk factor for this patient to develop breast cancer?
So for this patient,
Actually, there's a lot of echo from your side. Are you using two devices? Will you be able to?
No, I think it's their echo from all of us, our sides. Mine is also echoing, I think.
Okay.
So now is it better? Echo.
Yes.
Now it's better.
Oh yeah, now it's better.
I've stopped the computer already.
So you mentioned in detail about the menstrual history. So how significant it is for this patient in developing breast cancer?
So the patient has there is no history of early menarche for this patient. Less than 9 years, it's not there. It is 14 years, normal age itself. And menopause is also at the age of 45. So it is actually not a very long exposure to estrogen for this patient.
Do you think a history of oral contraceptive is really relevant for this patient?
OCP use is not there, sir. Because excessive estrogen exposure may be by using combined oral contraceptive pill and by assisted reproductive methods when the hormones are used to stimulate ovulation. In these two conditions,
this combined estrogen pill is more relevant in the setting of an hormonal replacement therapy. So that is where it definitely increases the risk of breast cancer. In this patient, I'm not very sure whether it is really relevant.
Right.
Okay, we can. So based on the history, it looks like a malignant tumor.
Yes, so because increasing in size.
Yes. Okay, you can proceed with examination.
So general examination. Patient operative and oriented to time, place, and person, moderately built and nourished. ECG performance status of 1. She is febrile with a pulse rate of 72 per minute. Blood pressure 130 by 80 in the right hand in sitting position. Respiratory rate 14 per minute. There is no pallor or edema. Now I'd like to go to local examination. In the local examination, inspection was done in sitting position with arms by the side, arms raised above the head, and in sitting position with hands pressing inwards on the hip. So a breast lump was visible just below the left. Breast lump was visible just below the left nipple. Nipple area complex is slightly higher on the left side. A biopsy mark is present over the left breast, and left breast is slightly larger than the right breast. And both the breasts move upwards symmetrically, and inframammary crease is normal. There is no PUD orange or ulceration or satellite nodules or dilated veins, erythema or nipple discharge. There is no edema of the left arm. Now, palpation in the supine position, the right breast appears normal. Left breast, there is no local rise of temperature or tenderness. A single mass of size 6 into 6 centimeter is present over the lower inner and outer quadrant of left breast, approximately 5 to 7 o'clock position, which is firm in consistency, has a smooth surface and well-defined borders. The breast lump is not fixed to the skin, chest wall, or pectoralis major muscle. There is no nipple discharge. Now, on examination of the axilla, a single mobile lymph node of size approximately 1 into 1 centimeter is present over the left axilla, which is firm in consistency. There is no supraclavicular lymph node enlargement of the left side. Opposite side axilla and supraclavicular area are normal. Systemic examination is unremarkable. PV and PR is not done because patient hesitated to give consent. There is no spinal tenderness. So, to summarize from the history and examination, we have a 45-year-old P3L3 postmenopausal lady with no comorbidities and history of right-sided oophorectomy 17 years back, presented with a left-sided breast lump, which was instantly detected 6 months back, progressing in size over the past 2 months for further evaluation and management. On examination, a single mass of size 6 into 6 centimeter is palpable in the left breast, 5 to 7 o'clock position, firm in consistency, well-defined edges with a single firm and mobile left axillary lymph node of approximate size 1 into 1 centimeter.
So, Parvati, you've explained the examination part in very detail. Actually, from a medical oncology perspective for a DM exam, this local examination on different positions may not be very relevant. You can definitely write it down, but when you present, I think it is more important to tell the findings. Like as someone has asked in the chat, whether mentioning about the inframammary crease, is there any significance? So such details, I think you can note it down, but while presenting, I think you can focus on the major
single
findings.
mass and everything. Okay. So, so now I'm done with the examination.
Yeah, so what is the idea of examining the patient in these different positions?
Sometimes the small mass can be missed. So, in palpation, we have to do it in supine position first.
Okay.
Let me say about inspection first. Inspection itself, we can see whether there is any purely orange appearance, and on sitting with arms raised and sitting with pressing the hips, we are making the pectoralis major taut, and we are seeing whether there is any increase in size of the mass.
Okay.
Or
okay, so the hips by the side was to make the pectoralis taut, and so what does that tell you?
There is no fixity, or
To
there
the
is no.
pectoralis.
Yes.
So does that upstage the disease?
If there is a pectoralis major fixity, it will.
Yes. It'll upstage.
Yes, sir.
Really? From what to what? So the size of the tumor is 6 centimeters. So as per the TNM staging, T classification would be?
It is T3, sir.
T3. So it would become T4 if...
Chest wall fixity will make it T4, sir.
So pectoralis constitutes chest wall?
No, sir. Not chest wall, sorry.
So what all constitutes chest wall in breast?
Ribs and intercostal muscle.
And?
Sir, serratus and posterior.
Okay, okay. So pectoralis fixity does not upstage the
disease.
Okay. So how do you look for chest wall fixity in your clinical examination?
So we have to make the patient stand near the wall. And we have to ask them to push against the wall.
Yeah.
And while at the same time, when we palpate, we can palpate to see whether there is any fixity.
To the serratus anterior. Okay. So that is how clinically you can differentiate whether it has become T4. Correct.
Yes, sir.
Right. So serratus anterior. Then what else did you gather from your clinical examination, the size of the tumor you mentioned 6 into 6, so that makes it T3.
T3, sir.
There is no fixity to any structures that you
No,
could
X ball or
identify.
skin, it is not there.
Okay, and then the node is also single, firm, and mobile.
Yes,
Single
sir.
and mobile, right? So that
Single
is
and mobile, sir.
that is clinical.
N1, sir.
Clinical N1. Okay, what is clinical N2?
When there are multiple nodes which are matted and which is fixed, and tumor node size more than 2 centimeters is usually 2 or 3 nodes which are matted together.
Okay. Can you clinically identify internal mammary nodes? This is probably just a hypothetical question. For practically, there is probably no relevance. But since you are giving an exam, internal mammary nodes.
I just know location. It is within 3 centimeters from the sternum, but I don't know clinically. No.
Clinically, how
no,
do
sir.
you identify? I mean, it's
don't know,
almost
sir.
always seen on imaging. Only a
Yes,
CT
sir.
would definitely tell you. But clinically, is there any way described? Although it is probably rudimentary as far as our practice is concerned. But a theoretical question.
No, sir, I don't know.
Is it by palpation? No, clinically, not radiology.
Percussion then, sir. Probably.
Percussion. Yeah, so that was the it was the examination method described. What? Sorry.
Okay.
Yeah, so you can look up internal memory is what they say. So can the internal memory, what would be the stage if you find an internal memory node? Say
It
clinical
depends
radiology.
on whether there is axillary nodal involvement is there as well.
Very good. So how would it change?
If there is ipsilateral axillary nodal involvement and an internal mammary node, it will become N3 sir.
Very good. Okay. Otherwise, it will be N2.
N2, yes, sir.
Can it be N1?
No, sir. Ipsilateral level 1 and 2 lymph nodes are only involved in N1.
Ipsilateral level? No, we're talking about internal mammary nodes. So a sentinel detected if internal mammary is supposed to be N1. Okay. Anyway.
Okay.
So I think we'll proceed. Any more questions? Clinical examination, Manu?
No, so we have covered everything. I think during summary, she can focus on the aspect where there is no fixity. All those conclusions can be brought into the summary. Otherwise, we've discussed everything.
Correct. Okay, Parvati, you can move on. How would you proceed with this case?
You can tell the final stage, Parvati.
Yeah, final stage.
Clinically, this is CA breast, CT3, CN1, MX, and stage grouping will be 3A.
So it's CT3 N1. So is it a
CT3
locally
N1,
advanced
sir.
breast cancer?
Yes, early breast cancer.
So what all constitute early breast cancer? What all constitute locally advanced?
Up to T3 and N1 tumors are early breast cancer, but regional involvement is there. No.
But actually, N1 would make it LABC, correct? So
T3
N1.
Yeah.
Yeah. So T3N1 is a subset of LABC, which is called operable LABC. So all this is relevant only with the prior AJCC. Correct, Parvati? The new AJCC, I'm also not sure about the new AJCC staging. But T3N1 used to be called the operable LABC, and beyond T3N1 would be, inoperable, where they would require new adjuvant. Yeah. So T3N1 is.
So be very clear on this, because we always usually mention as LABC, and if you do not know what it is, then we'll be in trouble. So this is actually LABC. T3N1.
Correct.
Qualification.
Yeah. Okay. So how would you proceed? Probable clinical breast malignancy, clinical T3N1, MX.
So I would like to do some investigations to confirm my diagnosis, then for staging purpose, and then for fitness.
Okay. So what all would you do?
To confirm the diagnosis, I would like to do a through-cut biopsy of the breast lump.
True-cut
And
biopsy
before,
in
prior to
the
biopsy, I'd like
uh,
to do a mammogram.
okay.
Non-invasive.
Okay.
Non-invasive evaluation. I'd like to do a bilateral mammogram at first. And
Right. What additional information are you looking for in the mammogram?
presence of any calcifications, diffuse calcifications or not.
Diffuse
And
microcalcifications, okay.
diffuse microcalcifications, axillary involvement.
So what's the problem with diffuse microcalcification? Suppose it is
we-
there.
We cannot go for any breast conservation surgery if
Very
there
good.
is
Very good.
diffuse.
Okay. Then
Then, sir, contralateral breast involvement, if it is if any contralateral breast involvement is there or not.
correct. That is also important for the opposite mammogram. The
Yes,
same
sir.
side mammogram.
Axillary involvement, number of nodes.
Okay. They can give an idea about the number of the extent of axillary involvement. Then
Yes, sir.
multifocality and
Okay, multifocality and multicentric. Okay, sir.
yeah. So those are the things which are going to affect our management.
Management.
And the trained mammogram radiologists may also give us an idea about the histology of the tumor, the histological subtype of the tumor. So that can also be gathered in some cases from the mammogram. Okay. So in this case, you were feeling a definite lump, right? So you could
Yes,
measure
sir.
it 6 into 6.
Yes, sir.
What are the conditions where you do not feel a definite lump? That means it would be very diffuse sort of a thing. So what are the breast malignancies where you expect such a situation where you cannot lump?
In occult axillary nodal mets, that is one condition.
Occult axillary nodal met means there is no breast mass.
Occult axillary breast cancer. There is no breast mass, but only an axillary node.
No, okay, so you don't feel a breast mass at all?
No, sir. That we do breast MRI to find out if it is there or not.
Okay, no,
Then,
we were talking about like something more diffuse. You cannot,
that is
delineate.
inflammatory breast cancer is there, sir.
Yes, very good. So inflammatory breast cancer is one where you may not feel a lump, but it will be a diffuse, sort of an ill-defined mass. Okay.
Yes, sir.
Then what else? Where else?
Post chemotherapy, sometimes we won't be able to.
No, we are not talking. We're talking about de novo case. Which is the other situation where you do not feel you feel a very ill-defined sort of a mass. In what sort of a breast cancer? In lobular cancers, correct? In lobular breast cancers, many a time you would feel a very ill-defined sort of a mass. Okay, since you said inflammatory breast cancer, what is inflammatory breast cancer? How do you call a cancer inflammatory breast cancer?
Inflammatory breast cancer is one which has ulceration.
Criteria for,
It is basically clinical.
Yeah, sometimes a
clinical
patient after biopsy can come with a lot of redness over the breast, around predominantly around the biopsy site.
That
Severe
is not
pain.
inflammatory breast cancer.
That is not inflammatory breast cancer.
No, sir. No.
Okay, and what is inflammatory breast cancer?
Inflammatory breast cancer is something which is it may or may not be associated with a mass and rapid progression in erythema, edema, and skin involvement within less than 6 months duration.
Okay, and it should involve. Is there something of that, like it should involve more than so much of the breast tissue?
More than 1/3.
Okay.
More than 1/3.
Okay, so that's inflammatory breast cancer. Fine. Right.
So, are there any specific characteristics for inflammatory breast cancers in general? What will be the behavior?
It is very aggressive tumor, sir, because it has
any clues for the molecular subtyping?
Yes.
No idea, sir.
They'll be usually high grade and HER2 overexpressing the hormones will be negative.
So, majority are considered to be HER2 overexpressing, correct. Okay.
Okay.
So yeah, how will you proceed now? You've got a mammogram, and mammogram is showing only this tumor, no diffuse microcal, no other no multifocality. The contralateral breast is say normal. So how would you proceed?
So I would like to do a biopsy for histological confirmation, a
Okay.
through-cut biopsy.
A guided biopsy.
Yes, sir. USG guided biopsy from the breast lump for confirmation.
Okay.
And with that biopsy specimen, I would like to do, if it comes as invasive breast carcinoma, which is the most common type, I would like to do immunohistochemistry tests for ER, PR, and HER2 status, and MIB or Ki-67 index.
So you'll do those things only if it comes as invasive carcinoma.
anyway, we'll
common
have to
subtype,
do.
other subtypes you won't do.
No, sir. Anyway, we will have to do.
So
Okay.
in carcinoma, you'll do all these tests, right?
Yes, sir. Any suspicious one we have to do.
Okay. So yeah, Manu.
Yeah, is there any role for doing an ultrasound of the axilla?
So we have a mammogram with the suspicious axillary node.
So there is no role for ultrasound guided axilla. Is there any situation
Actually, sir,
where it
is
is
there,
relevant?
if there is upper limb edema, to rule out DVT.
To rule out, I didn't understand. I didn't hear that.
No, sir. If there was any upper limb edema or symptoms, to rule out DVT
Oh.
and
No, that is not a common indication. I mean, it depends on how you're planning to manage the patient. So how you're planning to manage the axilla. So having an ultrasound axilla and proving the lymph node positivity, especially in suspicious nodes. If you're planning for SLNB, that will be helpful. That is one situation. And small tumors. Have you heard of a sound trial which was recently published?
No, sir.
So not for this patient, but small tumors, receptor positive tumors. If ultrasound axilla is negative, actually we can avoid axillary dissection or even SLNB. So axilla we need not treat surgically. So
yeah.
So in such situation, how we are going to manage the axilla is important. Certain situations, ultrasound axilla and sometimes FNAC may be helpful, though it's not a routine practice.
Yeah. Okay. So suppose this patient, it comes as ERPR positive, HER2 negative, and Ki-67 is 20%. How would you like to manage the case? And before that, this ERPR positivity, what is the usual method that we describe IHC ERPR positivity?
We do by Aldrich scoring system. Now it has come to be CAP scoring.
Okay. So what is Aldrich scoring? What are the, like, how much is it scored out of?
Aldrich score has mainly two components. We have intensity score and composite score. In total, one score is from 1 to 5, and intensity score is from proportion score is from 0 to 5, and intensity scoring is from 0 to 3. So we add both together and scored out of 8.
Scored out of 8. So ERPR strong positive, HER2 negative in this patient. So how would you like to proceed?
Because the patient is 45, and I would like to know the grade of the tumor as well.
Yeah, grade 2.
Grade 2. Okay. Since it is ERPR strong positive and HER2 negative and grade 2, but Ki-67 you told was 20%, sir. So that is one high risk characteristic, 20%. So I would offer her chemotherapy followed by adjuvant endocrine therapy.
So before that,
chemotherapy is
any staging for this
You have
patient?
staged
For
Staging
this
investigation?
patient or oncotype DX we can do 21 gene.
So, Parvati, you are completely out
You're
of
going
track.
on.
No? So we are talking about the neoadjuvant setting, right?
Yes, sir.
We haven't operated.
Before you plan your surgery, chemo, and everything, wouldn't you like to stage this patient because she is node positive?
Oh, yes, sir. The other
Okay.
investigations.
So that is what
Uh,
was expected, the expected answer. Okay.
Okay.
So how would you stage this patient?
I'd like to do a CT, contrast enhanced CT scan of thorax, abdomen, pelvis, and I would like to do a bone scan for this patient, sir.
So which all patients with breast cancer will require staging?
Sir, any node positive patient we do staging, sir. N1 patients we do staging, and anything more than stage 2 we go for staging assessment.
Yeah, actually, institutional practices may vary, but in early breast cancer, the role of staging
There is no role.
investigations
It is not there, sir.
not there. It should be done only if there are any symptoms suggestive of metastatic disease or abnormal
sir.
blood investigations like raised ALP. So, but this is a locally advanced breast cancer where we
have
can
to
do
do
staging as you said. But N1 alone simply will not qualify to
For
require
staging.
staging investigations. Practice may vary. So, in this patient, how likely you are? How likely you will get a metastatic disease, occult metastasis? In locally advanced breast cancer, what is the percentage of occult metastasis that can be detected with staging investigations?
So 20% approximately.
Yes, yes. If you generally we can say it as 20%. So it may vary based on the subtype, but generally locally advanced 20% can have occult metastasis.
Staging will be around 20%, correct? Yeah. So what is your institutional practice? How do you stage, say, node positive patient? Do they go for scan or PET scan?
No, so CT chest with bone scan is what we do.
CT chest with bone scan. Okay. Fine.
CT chest, abdomen, pelvis, and a bone scan.
Okay. So this patient has undergone CT chest, abdomen, and pelvis, and a bone scan, and all these staging investigations are negative. So how would you like to proceed?
Then we would like to assess the fitness of the patient as well.
Okay.
And before that, I'd like to ask the patient if they want the option of endocrine therapy alone or for chemotherapy as well.
No. Why would you ask the patient now whether they want endocrine therapy or you mean as neoadjuvant?
No, sir.
Wouldn't you
Neoadjuvant
like
endocrine, sir.
Okay.
Neoadjuvant endocrine, I would prefer if the patient was more than 70 years or elderly patient. But here I would go for neoadjuvant chemotherapy. So for that, to assess the fitness, I would like to get a cardiological assessment for the patient as well.
Okay, so wouldn't you like to get a surgical oncology consultation prior to making all the decisions,
And
because it's a
yes,
T3 disease? Yeah. So wouldn't you have to
after the
discuss with your team?
yes, sir. We initially itself send the patient for surgical oncology consultation at our institute.
So you have to tell that soon after the investigation, you have to tell that you'll involve your surgical colleague and preferably discuss in an MDT. So in this patient, it is very important because we are before planning NACT. So why is it important?
Because it is T3N1 disease, the surgeon will be able to assess whether they will go, what surgery they will be doing, and time taken for the surgical slot, and we have to plan the chemotherapy and all accordingly.
If this patient wants the BCS, what will be your opinion?
The BCS is mainly dependent upon the tumor breast ratio.
Okay.
And if the breast size and tumor size will be compared, and if possible, It's basically the surgeon's prerogative whether they will go for BCS or not. Since there is no family history and there is no prior RT to the chest wall, so I can arrange for, I can be okay with a BCS for this patient if surgeon.
The patient you've seen, so you feel she'll be eligible for BCS.
Yes, sir.
In that case, will you do any other investigation or procedure before starting chemotherapy?
Sir, I'd like to ask the surgeon to mark the tumor site with clip and the lymph node also with clip.
Okay.
And
So all neoadjuvant procedures you have
SLNB,
to tag it. Yeah.
sir, tagging should be done.
So
Because
suppose
we
the
can
patient
go,
does not want BCS. She says she wants a mastectomy. She wants to remove the full breast. So how would you proceed further?
even if we are planning for mastectomy also, we have to go for SLNB and
SLNB.
or because after mastectomy we won't be able to do FSK actually.
Okay, so you would be so if you are planning a direct surgery, you will be doing the mastectomy.
Sir? Pardon,
No,
sir?
I didn't understand what you said. You will be planning. Suppose the patient does not want breast conservation.
Okay,
What
sir.
sort of a treatment would you plan for her? Would you still like to go for neoadjuvant strategy and then?
No, it depends upon whether the date, basically, or because of the dates of surgery. If the surgeons are giving early date, we can
Date
go
is
for.
okay. Suppose date is open. You can get a date for surgery anytime. And this patient says she does not want BCS.
Okay, sir.
Yeah. Would you still have to go for a neoadjuvant approach in this case? ERPR positive, HER2 negative, luminal kind of a patient.
As a mastectomy can be done up front, it's okay, but
Okay. Axilla cannot be done.
axillary we can downstage. We can actually downstage the axilla and reduce the RT if we are doing NACT.
Reduce the what?
Reduce the radiation.
Reduce the radiation by giving chemo.
Sir, if axillary downstaging.
So you mean to say if you are doing neoadjuvant chemotherapy, you can avoid radiation if the axilla becomes negative.
We have to give. I'm sorry, sir.
Okay. So this patient, if she does not want BCS, can't we straight away go for an MRM?
Yes, sir.
You can.
After SLNB.
After you would, suppose we have proven the axillary node to be positive by FNA.
Okay, sir.
Then how would your management be? I mean, how would you manage it at your institute? You have a T3N1 case and a single node is there in the mammogram or ultrasound of the axilla, and you've proven it to be positive, the node.
Okay, sir. Then we would go for neoadjuvant chemotherapy itself, sir.
You would want to go for neoadjuvant chemotherapy?
Yes, sir. And prior to NACT, we would be tagging the node as well as the margins would be tattooing would be done for the breast. Sir.
So actually, why do you want to tag the node? You'll be removing. What will be the strategy after NACT? How will you address the axilla after NACT?
After NACT, for this patient, if we are decided on MRM, we'll be going for MRM. And in MRM, they will also be removing prior to MRM, we'll be doing SLNB. And SLNB at that time, this positive node will be removed and any other suspicious nodes will be removed, sir.
Okay, that means there is no need of clipping, right?
Sir?
There is no need of clipping, right?
Because after NACT, if the node becomes N0, YC N0, we need to know what area.
So your institute, you follow after NACT also, you follow targeted axillary clearance or something like a sentinel node. That's what you mean.
Yes, sir. Yes, sir. We do that.
Okay. So post NACT, SLN is done so that axillary mobility is reduced. That's what you're saying, correct?
Yes, sir.
Okay. So that's not a usual practice in many places. So many centers do not do SLNB after NACT. I mean, of course, it's not a contraindication. Uh, but since she's going for mastectomy, you wouldn't need to clip the breast tumor, right?
We'll be tattooing. Mastectomy is there, so no point in clipping. Yes, sir.
No going to clip it. Okay. So that is clear.
Yes, sir.
Okay. So the patient has, so you would like to go for neoadjuvant anyway. Suppose I say it's a patient is ERPR positive, HER2 negative, and key is 8%, key 67. Would you still
Okay.
consider neoadjuvant strategy for such a patient?
No, neoadjuvant hormonal therapy can be given, sir, because it's low Ki67.
No,
Mhm.
I
Or
will.
adjuvant endocrine therapy can be given. Adjuvant endocrine also can be given, sir.
No,
So you will
adjuvant
take up
endocrine.
the
Manu, carry on.
no, sir. No, so you'll take up for upfront surgery and then plan for adjuvant treatment based on the histopathology.
Yes, sir.
So
So
you
you
can
have
take
been mentioning about adjuvant. You have been
Manu,
mentioning about sorry. If you want to ask, you can ask.
carry on.
You have been telling about the neoadjuvant hormonal therapy. So can you tell something about it? Which all situations will you use it? So what is the expected response rate? Can we use it before breast conservation?
So basically, neoadjuvant hormonal therapy is for given for elderly patients more than 70 years with other comorbidities who are strongly hormone positive and probably N1 disease. The rate of attainment of pathological complete response is less than 10% only. Low.
Clinical response? Clinical response?
Clinical response will take nearly 3 to 4 months to identify, but there will be only minimal reduction in size.
Yeah, generally we give it for 3 to 4 months, and 40 around 40% will have good response, and even some of the tumors can be converted to something like a BCS. So, but we generally reserve it for elderly patient, not for this patient.
Yes.
Okay. Suppose you've gone for straight surgery.
Okay, sir.
No, you said you wanted a neoadjuvant for this patient, right?
Because it is 6 centimeter tumor, sir.
That is to facilitate BCS.
BCS. Yes.
Okay. And even if she does not want a BCS, you would still like to go for a neoadjuvant therapy.
Yes, sir. Because pathological CR attainment will be
Pathological CR attainment will be how much of pathological CR are you expecting in a luminal patient with neoadjuvant chemotherapy? Yeah, so that is not
hormone
going to be a
positive.
very significant number in hormone positive luminal tumors who undergo neoadjuvant strategy, right?
Yes,
So we're probably not very worried about a pathological CR in this patient. To facilitate a BCS, yes, of course, you can go for a neoadjuvant strategy. Again, we should understand that a luminal tumor is not likely to. And since you are practicing, as you would like to do that because you want to reduce the axillary morbidity, correct?
Yes, sir.
Okay. Right. So what neoadjuvant chemo would you give her then?
Because she is a 45-year-old and good performance status patient, cardiac contraindications are not there.
Okay.
I would go for a dose dense AC followed by taxane, sir.
Okay.
And
Right.
endocrine therapy will be added.
Dose dense AC Taxol followed by surgery, and then
followed by
all the
adjuvant
other,
endocrine therapy or depending upon no, sir, adjuvant endocrine therapy.
adjuvant endocrine therapy. Suppose the post-op histopathology comes as PT2N2.
YPT2N2.
YPT2N2, correct. You give a new adjuvant?
She's progressed.
She is,
Uh,
we are not really say progress. Probably she had multiple nodes at time also. Say number of nodes or 5 nodes were involved, which was not picked up by ultrasound. So not really sure whether it is progressed, but might have been there. So what would your strategy be? How would the strategy differ? What would be your adjuvant treatment in such a case?
Our adjuvant RT anyway we have to give, sir. Adjuvant
Okay.
RT to whole breast with the boost to the tumor bed.
Boost
And
to BPS you have done, okay.
no, sir. Adjuvant RT and chest wall.
Okay.
And
Adjuvant radiotherapy, fine, okay.
yes, sir. And along with it, adjuvant endocrine therapy.
Adjuvant endocrine therapy. So based on recent information, is that going to be okay for her? Adjuvant endocrine therapy for how long? What endocrine therapy and for how long?
For this patient is postmenopausal. So we can give adjuvant aromatase inhibitor.
Okay, for
5 years.
For 5 years. Is YPN2? Would she be a candidate for, the extended hormone therapy?
Up to 10 years. Yes, sir.
So who are those patients who are going to benefit from, the extended hormone therapy?
The young female node positive post YP more than N1.
Okay, all node positive patients, younger women are going to, probably benefit from an extended hormone therapy. She would definitely benefit because if she's YPN2. What else would you consider in her? She's luminal, she's YPN2, and you've decided for and given radiation. You have planned hormone therapy. Is there anything else in the current era that you can, add to her treatment that may give her some benefit?
CDK4/6 inhibitor abemaciclib.
Okay. So you had to be probed to get the answer. So what is the evidence for that?
Sir, Monarch trial.
Monarch which one? Monarch 1, 2?
Oh, sir. Monarch trial, sir.
Monarchy, okay. Monarchy gave evidence for adjuvant
Abemaciclib and endocrine therapy.
Along with endocrine therapy. Okay.
Will you use ribociclib as adjuvant? What is your take on that?
The OS benefit is there for abemaciclib.
Ribociclib doesn't have.
What is Natalie?
Ribociclib.
அடிச்சு நவுத்துறானுங்க அதான் சொல்லிட்டேன்ல.
So Natalia has shown a benefit with FONRMG ribociclib also, but the full, I think only the interim results in the form of abstract is available. So we need to wait for the full paper, I think. And Parvati, if this is a triple negative breast cancer, how will your treatment change?
Triple negative breast cancer, we'll do germline BRCA testing, sir. And germline BRCA testing, if it is pathological variant is identified, we would go for adjuvant olaparib.
Okay.
That is the adjuvant olaparib doesn't have any role if this is hormone receptor positive, because you brought it in. I'm asking.
No, hormone receptor positive also no pathological CR, then we can give adjuvant olaparib.
No, actually,
if germline.
You said no role.
No, there is role, sir.
So which all situation will you suggest adjuvant olaparib?
At this present situation, hormone positive HER2 negative breast cancer, post NACT, not attaining pathological CR, and no N2 with germline
Foreign
BRCA
or not
content.
positive. Yeah.
Hello, sir. Hello.
Okay.
And then TNBC, germline
Yeah.
pathological variant positive.
Okay. So hormone receptor positive also, if they're high nodal positivity and high
Go for
chance of
adjuvant olaparib.
benefit from adjuvant
Yes.
olaparib. So I was asking about how will your yes, overall treatment change if this is TNBC? Will your drugs change? Will your regimen change?
Yes, sir.
Starting from
If it is
diagnosis.
diagnosis,
No, starting from the initial management itself.
okay, because neoadjuvant chemotherapy will anyway give for TNBC because rate of attaining pathological CR is more for neoadjuvant chemotherapy.
Correct.
And the drugs which I would use also will change.
How will it change?
I would first, in the diagnosis itself, I would check for CPS score, combined positivity score for PDL1 as well.
Hmm.
And if it is more than 10%, I would go for pembrolizumab and pembrolizumab based chemotherapy, like Keynote 522. And if
So we would like
TNBC,
to.
BRCA, sir,
Yes. Carry on.
TNBC, BRCA assessment will, BRCA testing will also be done, sir, initially. And
Okay.
we go for pembrolizumab plus paclitaxel and carboplatin chemotherapy initially as
Followed by?
followed by surgery.
No, on
Then
paclitaxel and pembrolizumab.
Initially for 12 weeks and then AC chemotherapy, adriamycin cyclophosphamide for 4 cycles, followed by surgery. And depending upon the PCR status, we would decide on the adjuvant treatment.
Okay. So you need PDL1 positivity. This benefit is only for PDL1 positive patients.
PDL1 more than 10%, CPS more than 10% in metastatic setting, we need more than 10%.
The neoadjuvant setting, I think, irrespective of the
This is-
PDL1
Neoadjuvant
status,
irrespective.
patient that benefited.
Keynote 522.
Okay. If the patient cannot afford pembrolizumab, will you add any other drug?
Platinum-based chemotherapy.
So how will you involve platinum in the neoadjuvant setting?
Uh,
So your regime would have been dose dense acetaxol, right? Dose dense AC.
paclitaxel carboplatin.
Okay. Although it is not standard, probably that is one addition where you can make in TNBC. Still not considered a standard practice all over, but there are centers who do it. So probably if you are asked for an addition, yes, paclitaxel with platinum can be used. Right.
You should know about the latest trial from TMH also, because it's a controversial topic, but you should all this aspect.
And post surgery, you've done NSCT in TNBC. She's undergone surgery. Is there anything else that you may have to offer in her?
If she is not attaining PCR, then we can give adjuvant capecitabine.
Capecitabine. Okay. For how long?
The 8 cycles, 3 weekly 8 cycles. That is for 6 months.
For 6 months. Okay. So no PCR, she can. So what was the evidence for that?
CREATE-X trial, sir.
Okay. So based on the CREATE-X, you can give adjuvant capecitabine for a period of 6 months. Okay.
Yes.
So
Is there
how will
any
you
other?
follow up this patient?
Yeah. Okay.
Sir?
How will you follow up this patient?
So after RT, and my present patient is hormone positive breast cancer, so we'll be giving adjuvant RT and then adjuvant endocrine therapy. After 6 months after RT, we'll first do a mammogram, and then which is repeated yearly mammogram. And every 3 months, we will be doing clinical breast examination for the first 2 years. After that, every 6 monthly examination till 5 years. After 5 years, we'll be we'll be asking her to visit us once a year only.
Okay.
Okay, so you said the first mammogram is after 6 months.
After 6 months to 6 months of RT only, we'll do the first mammogram, RT and surgery.
So that's the usual. Okay.
Okay. I think it's almost time, no, sir? Arun sir.
Yeah, I think 8:30. Okay.
So
Is there anything else that we need to?
I think you can just give a summary where, overall opinion and any points of improvement, and then we can close the session.
Yeah, I think
Dr. Arun? Yeah.
I think the presentation was good, and the initial flow was there. But of course, as Manu said, whenever you give a history or be it a negative history or mainly the negative histories, you should be able to substantiate why you put that negative history inside, and even your examinations, why you chose this particular position, all that you should be able to substantiate. So many a time, candidates, for that matter, have this tendency to keep giving negative histories one after the other mechanically. But once you're stopped in between and the examiner asks you, why did you give that? That is the time when you will be thinking. So think beforehand, and before putting in a negative history, think why I put it down, and you should be able to substantiate that point. And also be confident with your institutional practice. Many institutes have kind of varying practices with regards to neoadjuvant strategies and even adjuvant radiation strategies, all that. So be very clear about what your institute is doing, and so that will probably save you at many places. You're going to get very cases which are into a lot of gray areas, and one thing you can use to defend is by quoting your institutional practice. So be very thorough about your institutional practice. So I think overall it is good enough. You answered most of the good questions. So Manu.
yes, I also agree. She presented very well. But as Arun sir said, we should focus on the important findings, positive findings. And I think I'll suggest to note down everything, but when you present, only highlight the important aspects. Otherwise, unnecessary questions will be there on those negative histories, and a lot of time will be lost. So you can focus on the important findings and positive history. And then as you can always explain based on the institutional practice. Nobody is going to question that. Any rational practice that you're doing in the institute, you can always tell that. And don't lose track. There will be several questions explaining different scenarios, but always think of your patient and answer accordingly. Like, this is exactly what you do in the clinic. You just need to answer them in a structured way. So don't lose track, and like you brought in Oncotype DX when we were discussing about the neoadjuvant chemotherapy. So like that, don't lose the track. And another thing, in certain aspects about other specialties also you should know basics about the surgery. And radiation, we didn't ask anything, but a few points we should be knowing. And certain usual things like the epidemiological things and PATSIA rates, generally they ask that, we didn't go into. Otherwise, she presented well. Only these points also can be stressed on.
Okay.
Any other
thank
comments
you.
on the, if any senior people are there, can also give comments.
Not too many senior people now. So a lot of students are. We had over 160, 170 people listening to this. So I think it was great. It's in depth. We went through the coverage, and practice makes perfect. So I think with more time, you will get better. So, and it was a good discussion. Thank you to all the participants who joined in. Thank you to Dr. Parvati for presenting, giving us your time, and thank you to both our examiners also for spending their valuable evening with us today. So hopefully we'll see you in the end of this month or early next January. Thank you and good night.
Thank you. Good night.